All right, I think we're ready to go. Welcome everyone to Your Amigos Live 2023. Yeah. I just wanted to get some applause because Tom's been getting recent applause, so I needed a little love there. So, yes, thank you. So welcome. It's really an honor for Tom and I and the whole Mashup crew to host you all in Nashville. Lots of fun. You can see we've sort of blown out from last year. Those of you who were here last year, we've got better backdrop, better chairs, bigger room. So big upgrade one year to the next. I have a few intro slides before we start the live stream. So first is around our partnership with Mashup Media, and you've gotten to know the Mashup crew, Courtney and all the crew. We've had a great partnership with Mashup for probably a couple years now, 18, 24 months. And so Mashup is obviously a media company, and GU Oncology now is their major GU product where all the great GU content is, and that's who's been hosting our podcast, again, for the last couple years. So it's been a great partnership. They've put a ton of work into doing this meeting. You can imagine doing live meetings, as everyone in this room knows, is a lot of work. So thank you to Courtney and Carrie and Claire and anybody I forgot and of the Mashup crew. They've really done a ton of work, and we're super grateful. Yeah. Well, you don't have to clap for everything, but thank you for that. Yes. Okay. All right, there's a number of groups in the room that I'm going to point out. The first is our golden ticket winners. So for you Willy Wonka fans, you know golden ticket, for those of you old enough to remember. So this came up last year. It's just sort of a way to get other people involved, often early career investigators involved. So they're all in the room. Regina, Hedya, Renee, and Vadim, I think are all in the room. And they won. You can see sort of in the box below how they won their golden ticket. Regina and Vadim were around suggesting either topics for the live stream or podcasts. And Hedya and Renee were around, we had a photo competition. The last thing we did was a photo competition around who could hold a Your Amigos sign in the most interesting place. And this was a conglomerate of the photos. And actually, Renee surfing on the upper left was, I think, the first photo posted. It was pretty much a slam dunk that she was going to be part of this. And then Hedya, you can see with the Your Amigos star in the Hollywood Square. And I found out last night she actually made those letters. Yeah. So incredible effort. And this is really successful. I don't remember whose dog that is. Shilpa's showing off some merch. So thanks to everyone for participating. I think we'll blow this out a little bit more next year. All right, we also have what we're calling Rising Stars. Tomorrow, midday, we're going to have a Rising Stars session, and we'll explain more about it at the time, but we're going to, we asked each of them to bring a concept, and we're going to talk a little bit about the concept and how do you get from concept in your head to actual execution of a trial, which is incredibly difficult and sort of a black box, I think, for a lot of investigators in general. And so that's going to be the topic of that session, but you can see all, and I think many to all of them are in the room here. It was just another way for us to help promote early career faculty, to get them involved, and again, it's part of our mission in terms of what we try to do with the podcast and otherwise. So welcome to all of them. Thank you for coming. Obviously, thanks to all our corporate sponsors who are in the room. Many of you are repeat sponsors from last year. Quite obviously, we couldn't do this without all of your excellent support. This is a very different kind of meeting by design, right? We don't want this to be like any other meeting you go to, and I know that takes some creativity around thinking how can we sponsor this meeting, but we've had nothing but really excellent sponsorship throughout last year, and even more so this year, so we're eternally grateful for your support. All right, here's an agenda overview. Obviously, Friday on the left, tomorrow on the right. So today, in about 4 minutes, we're going to kick off the live stream session on frontline bladder cancer. Quite obviously, there was a ton of data at ESMO, and so we'll talk all about that. We're going to then switch up a little bit of the panel, and our second part of bladder today is on non-muscle invasive bladder cancer, where there's actually a lot of drug development in recent years. We'll take a quick break to do a stage reset. You'll see what I mean. And then we're going to have something called Your Amigos Cup that I think Tom's going to explain on the next slide. This is sort of a Tom brainchild. You'll realize this when you see it in action. And we have 4 teams, and we're going to do semifinal today, semifinal tomorrow, and then the final agenda item of the meeting is to do the final round. And then tomorrow, we're basically prostate in the morning, Rising Stars midday, and then kidney cancer in the afternoon. Your Amigos Live is the hashtag on Twitter, so for those of you on social media, you can follow that, and we have social media folks planted around the audience who will be tweeting, still called tweeting, posting, reposting, et cetera. So please be active on that. It really helps us sort of get the word out about what's going on in the room for those that can't be here. All right, Tom, I'm going to turn over to you to explain in brief the Your Amigos Cup.
So I've been asked to do this very briefly. Thank you for coming. I'm not sure this is going to work. We haven't done it before. If it doesn't work, we'll do the best we can. There are going to be 2 teams of 3, and you can see the teams outlined here. There are going to be 2 semi-finals and a final. They're going to be asked questions predominantly based around medical oncology, but not exclusively. The game show lasts for 40 minutes, and it comes to an end, and whoever has the most points at 40 minutes will then go through to the next round. The final is tomorrow afternoon, and there is a cup, Brian, which we've bought a cup, which you're going to see in a second. We're very excited about this. It's like one of those hockey trophies. And whoever wins that can take it home and put it on their shelf for the next year. And then if this was a success, then we'll have another one next year. And if it wasn't, we'll have to find another way of you winning the Your Amigos Cup, which might be to do the best photograph. Who knows? So we're looking forward to that this afternoon. I'm not sure how it's going to go.
Yes, this was really an outgrowth of the buzzer rounds. For those of you last year, we had these buzzer rounds, and so you'll see there's buzzers. They're pictured on the screen there. So this was sort of an outgrowth of that. So should be entertaining. All right, and then we're going to start the live stream. Is that clock in the back correct?
It's bang on.
This will be the first time our timing was on in a while.
It's a miracle.
So again, the first hour is bladder cancer panel, and it's live streamed. There's a Zoom link, and we've been posting around, and it's going to be about frontline bladder cancer again with all the data. So with that, we will.
Brian, just before we go, we've got David online, haven't we? So if those people at home who are online, if you want to put chats to David, David's going to put your point up on. And ask the question on your behalf. So please do feel free. I know Cora Sternberg is online. I saw that. She was actually one of the first people on. As you know, Cora developed MVAC. I was speaking to Chris Boshoff this morning, who is a real fan of urothelial cancer. And Chris was telling me about how Cora developed MVAC and how exciting it was at the time. And so Cora's online now, and we're going to have a discussion about whether first-line platinum-based chemotherapy still remains the standard of care. So Cora, congratulations on your amazing work to date.
So yeah, for everybody online, if you just put your comments or questions in the chat, we'll sort of collate them, and then depending on what comes out, we'll try to integrate them. And I should have mentioned, for those of you in the room, we have a couple of mic stands that I can't see because of the lights, but are in the corner of the room, and we also have a handheld mic somewhere. So if you have a question or a comment, we'd love your input. Courtney in the back has it, so just give a wave, either stand up and ask a question or give a wave. We'd love your participation. All right, let's kick it off. So frontline bladder cancer, what just happened? Before we do that, I'm going to let the panel sort of introduce themselves. Jonathan, we'll start with you.
Hi, I'm Jonathan Rosenberg. I'm a medical oncologist at Memorial Sloan Kettering Cancer Center, focusing on bladder cancer.
Tom.
And I'm Tom Powles. I'm an oncologist from London.
I'm Shilpa Gupta, GU oncologist at Cleveland Clinic.
Matt Galsky, GU oncologist at Mount Sinai in New York.
Awesome. All-star panel. Thanks for joining. All right. So we're going to talk about frontline data. As you know, at ESMO, Checkmate 901 and EV302 were presented. And this is a slide that looks at whether the 901 results are, as Tom put on the slide, a black swan event, or does this sort of fit in with what we knew about chemo plus IO? So as you can see, the table on the top is the cisplatin plus X, Y, or Z, the PD-L1 or PD-1 inhibitors, Atezo, Nivo, and Pembro. Second column's response rate broken down to CR/PR, and then the PFS hazard ratios and 95% confidence intervals for the trials, PFS on the left, OS on the right. And then the last column is about subsequent IO therapy for the control arm, right, which obviously would be important in this kind of comparison, which varies. And then the bottom is just basically the graphical representation of the data. So Jonathan, I'll start with you. When you heard the 901 data, when you saw it, whenever that was, what stood out about it? Why is it different, or is it different at all?
Well, this is the only trial combining platinum-based chemotherapy and bladder cancer with a checkpoint inhibitor that was positive. Right. And I think the distinction really is the fact that it only enrolled patients receiving cisplatin-based chemotherapy as opposed to a mix of cis and carbo. And that's generally, I think, what you can see from the other trials when you looked at the cisplatin cohorts of patients on those trials, that there appeared to be a benefit. The studies were not designed to show that, and there is some provocative and interesting data suggesting why that might in fact be on a biological basis that Matt is actually the expert on, I would say.
So you believe it? You think the data is real? You think it's distinctly different from the other studies?
I think it's distinctly different from the other studies. And I think the evidence of that is in the cisplatin-based
Jonathan,
cohorts.
do you think the numbers are about the same, though? Like, you've got 0.73, 0.72, 0.67, and then 0.76, 0.78, 0.88. And actually, the lowest hazard ratio, those are the cisplatin. So do you think the Nivo is distinct from Pembro? Because if you look, actually, the Atezo data has got the lowest number at 0.73, and the Pembro has got the lowest number for PFS. So the Nivo doesn't have the better numbers.
I think it's not a Nivo, Pembro, or Atezo issue per se. It might be that, putting aside the PD-L1 versus PD-1 question for a second, they're all trending in the same direction here. And so, and again, not statistically sound to make these comparisons. We all would agree with that, right? This is like.
But you can do meta-analysis. You can do meta-analysis. That's allowed, and that's what we're essentially doing. So that's not.
Right. Well, you haven't actually done the meta-analysis, but you've shown.
That's a detail. That's a minor detail.
So, but you do see that directionality, they're the same. And I think that's the interesting point. And that Nivo chemotherapy in this study in a particular population doesn't look that different than those populations treated the same way with a different checkpoint inhibitor in the other trials.
Shilpa, what do you think?
I think, we don't want to do cross-trial comparison, but in the IMvigor 130, the use of cisplatin was based on investigators' discretion also, so it's possible a lot of patients who could have received cisplatin received carboplatin, and perhaps that diluted the effect. But this CheckMate 901 is specifically testing in cisplatin-eligible patients, so it's a little different. But I agree with Tom. It's not a remarkable difference across trials, if we wanted to just comment on that.
More a trial design issue, not a drug issue. Yeah. Matt, and I know you've talked a lot about cisplatin as a better partner. Do you think that's the only issue here, or are there other issues?
I think that's the main issue. I mean, I think, this is sort of an example of the reverse translational research paradigm, right? On subset analyses, a hypothesis is generated, you establish the biological plausibility of that hypothesis, and then you test it prospectively. So we could argue about this a lot, but that's the exact thing that's happened in the confirmatory study, did confirm the hypothesis that there's something different about this regimen.
Do you think the increased number of patients who got subsequent IO in that study, although not that different from Nivo, makes a difference?
In CheckMate 901?
Yeah, or in general, right? That last column where we list the subsequent IO therapy for the control arm.
No, I mean, that would have diluted the effect.
I mean, the outstanding one is Atezo, only 25% is low. And the question for me is, have we resolved the PD-L1, PD-1 issue? And are we comfortable that these drugs are interchangeable?
While we're on that, though, I think because you have the numbers up there, because this maintenance thing keeps coming up, and I hate to jump the gun because I think you're going to bring that up.
Yep.
But if maintenance made the difference, we should have seen that in phase 3 studies where maintenance was much less utilized because it just wasn't around at the time. So if maintenance is the different in 901, then why didn't we see a benefit in IMvigor 130 or Keynote 361.
Well, but maybe you would have seen a benefit had it been restricted to just cisplatin.
Well, then you agree with the cisplatin hypothesis, right?
Yeah, no. Yeah, that's what I'm saying. All right, let's move on. So, yeah, again, leading into this, right? How much of the benefit in this? So, Matt, how much benefit from the chemo-Nivo, right, seen in 901 was from the maintenance? Right, you see from Tom's poll on the right that many to most people will get avelumab, right? And that was sort of just a general question. Obviously, it's a Twitter poll. I don't know if there's real-world data. And then the bottom is just subset analysis from Javelin that shows that benefit of maintenance regardless of the type of platinum that was given in the initial chemo regimen. So, Tom, I'll let you start on this one. Do you think that what was seen in 901 is from some sort of interaction of Nivo and chemo and maintenance, or just maintenance?
So I think in all of these trials, maintenance therapy has helped a little bit. The question is, has it helped entirely, or is it only partial? And we have been quite comfortable until recently arguing that the chemotherapy and immune therapy is essentially antagonistic, because 361 and 130 were negative, and they had that maintenance period, and because Javelin was positive, all of the benefit was coming from the maintenance period. If you can assume that 50% of patients get maintenance therapy, and I think people say, only 10% of patients have progression of disease on chemotherapy. That's not what maintenance therapy is about. Maintenance therapy, you have to have that first scan, that's at 3 cycles, but then the second scan at 6 cycles. You can't progress then, and then many patients have 10 weeks before they start maintenance therapy. So actually, yes, only 10% progress on the first scan, but then it's 30% on the second scan, and then another 20%. So 50% feels about right. Now, we know in the real world only 20% of patients are getting maintenance therapy, and that's a different issue which I think we should discuss. It's like that neoadjuvant chemotherapy issue. We haven't really jumped on board in bladder cancer in the same way as the breast cancer doctors have done in adopting standard therapies, and we need to have that discussion as a group. But the issue here is, let's assume it's 50% get maintenance therapy, and the benefit of maintenance therapy, the hazard ratio is 0.70, 30% benefit. So it's only half the patients getting that benefit, so that's 0.85. That's a 15% absolute benefit. So you can assume somewhere between a 10 and 15% benefit. And so therefore, maintenance therapy, I guess if you started at the beginning of therapy, we could all agree the hazard ratio would be less than 1. And I would suggest it would be about 0.90 or between 0.85 and 0.90. I think assuming 0.70, that would be extreme. But I think assuming there's no benefit of maintenance therapy would be foolish. And so I guess you could say that 0.78 there, you could probably take 10 points off that and make it about 0.88. And that comes back to Matt's point, is there some benefit? And I don't think there's complete antagonism between chemotherapy and immune therapy. I don't think the benefit is huge. I think there is some antagonism, but I think there is probably a little bit of benefit. And if I was a patient, would I want to miss out on getting any immune therapy, which you could do if you start with chemotherapy and maintenance avelumab? I would like to have that immune therapy.
It's a really long answer. So there are a lot of numbers in there. I was trying to keep the math straight. So I think what I heard you say is you think that there's both. There's benefit of combination,
I think
and there's benefit of maintenance.
I think at least half the benefit in that trial is coming from maintenance.
Because you wouldn't expect that degree of benefit from maintenance alone. Is that what
I think that's about maintenance therapy. It's the upper end of maintenance therapy.
Okay. Jonathan, what were you going to say?
Well, I think the problem is that a lot of patients don't ever get to a checkpoint inhibitor. I think Tom was trying to make that point, and that
I thought it did make that.
that patients, if they start out with a checkpoint inhibitor, you're at least not seeing a decrement in the effectiveness here. And probably you see those curves, they split before 6 months, albeit very slightly, and that continues to track pretty closely up to 24 months. And then you see the curves really widen, and obviously the number of events the number of patients at risk is low when you get out there. But that's a real improvement, and so I think if we're using platinum-based chemotherapy, it argues that we should start with a checkpoint inhibitor.
So those patients, for no other reason, so patients don't miss out on the ability to get it.
And I would say only with cisplatin.
Yes.
Right.
Okay. Shilpa, did you have a comment on your feeling about, no math please, if you have a feeling about, the role of maintenance nivo in this versus the combo? I know we can't sort it out, right? We're speculating, of course, because we don't have the trial.
I think if we see the curves, they do separate out probably after the chemo period is done, so I think the maintenance does play a big role. So I wouldn't say that everybody should be offered the triplet, but if they have a lot of disease burden, then you might argue that we don't want to lose out those patients and offer this. That's my take on this.
Matt?
I would just say that it's not really maintenance in this setting. There are probably patients who benefit from platinum and patients who benefit from immune checkpoint blockade, and there's probably something about giving the combination. But the patients who are benefiting from immune checkpoint blockade are now benefiting when you start it up front rather than when they're getting as early second-line therapy, which is maintenance therapy. So I'm not sure it's maintenance therapy. You're just increasing the likelihood that those patients who are going to benefit from immune checkpoint blockade are getting the treatment.
Whatever that fraction that's destined to benefit they're getting exposure sooner.
Yeah, and,
Right.
and continuing it, we all have patients who we stop immune checkpoint blockade for one reason or another when they've only had a little bit of exposure, and then they do start to progress, months after that, and you can restart it potentially.
Yeah.
And so the benefit of continuing it is just the same benefit that you would continue it in the second line setting. You don't stop after 6 treatments, you keep giving it.
Yeah. So this is basically building on, I think, what at least one of you mentioned about, it's sort of just reiterating is the benefit in the maintenance phase. So I think the point of this was that the curves are mostly overlapping up to 6 months. Obviously, this is both 901 and the Atezo and Pembro studies, right, that are listed here, and these are PFS curves, obviously. So this would at least imply, graphically, and I think 901 is a little bit different, that the benefit is really, the curves start to split in the maintenance phase, right? Do you buy this or no?
But that's what we see with, I'm not gonna answer with too much math, but maybe a little bit of math.
Good.
A little's okay. That was just too much. Yeah,
So
that
the
was
single agent response rates with immune checkpoint blockade are 15 to 20%, 15 to 25%, right?
Yep.
In that range. And with chemotherapy, it's 40 to 60%. So you're seeing those patients, those 15 to 25% of patients, that's that benefit that you're starting to see after you've weeded out those responses to chemotherapy, which are generally much more heterogeneous in terms of the response durations. So I don't think that's a maintenance effect. I think you're seeing 2 sets of drugs which have different response proportions and different response durations, and that's what the shape ends up looking like.
But we can all agree during that first 6 months, there is no progression-free survival benefit for the combination.
For the combination, because there are more patients who are responding to chemotherapy than there are to immune checkpoint blockade. But the two on the curves with immune checkpoint blockade alone look just like that.
And it's only when the chemotherapy stops that the curves go up.
That's because of the median duration of response to chemo.
And there are 2 ways of explaining that. There's your way of explaining it, and there is another way of explaining it, and that alternative way is saying that the 2 make no difference when they're together.
I agree.
It's possible. It's a possible.
I agree. There are 2 ways.
Yes.
There's the
correct way,
and then there's the right way.
The correct way. Shilpa, any thoughts about this? I mean, I know, we're sort of beating this, but anything about, do you believe, obviously we're just sort of looking at curves and making inferences here, and I think Matt's saying that you have different susceptible populations, right? And obviously there's more chemo susceptible, right? So of course you're not going to see a difference because both arms have chemotherapy, and it's not until you get to the tail, which is where IO shines, if you will, that you see the difference.
Yeah, I think the sooner you start IO after chemo, I think you would see this benefit with, if there was not a 10-week lag after chemo, which that's what Jonathan was saying, we may lose patients in that way. So I think that's what we are seeing here, that there's really no gap between the start of IO from chemo.
Yeah, you're capturing more patients and you're moving it earlier.
Right.
Okay. Tom, anything else you want to say? Okay. You seem to be very passionate about this. All right, so this gets into the cis versus carbo, and Matt, I'm going to call on you. So this is a slide that looks, again, it's the same 3 trials. At the cisplatin population or the carboplatin population for the 2 that didn't include those. Difference in complete response rates of combo versus chemotherapy, difference in overall response rates, and then again the PFS and OS hazard ratios and 95% confidence intervals. So we see some differences, but maybe not massive differences, right? And so I guess, Matt, you've talked a lot about cisplatin as a better partner for IO. Maybe you could just, number 1, touch on the mechanism of why that might be the case, and then what do you think? Do you think there are real differences here based on these numbers?
So from a mechanistic standpoint, I mean, there's speculation, and then there's the data that's already in hand. And the data in hand, at least in IMvigor130, suggests that if you have features of adaptive immune resistance in your pretreatment tumor, then you do better with cisplatin alone, regardless of whether or not you get immune checkpoint blockade. And what that suggests is that cisplatin might be reinvigorating an immune response rather than inducing an immune response. Very different, I think, to what we think about a lot of times with chemotherapy, the concepts that you're going to induce an immune response. I don't think that's the case based on what we saw in IMvigor130. So that's with cis. You don't see that at all with carbo. And then when you add immune checkpoint blockade on top of that, you get a bit of a boost. But cisplatin in the context of tumors that have pre-existing adaptive immunity actually does the bulk of the immunomodulatory work. And then the immune checkpoint blockade adds something to that. And you don't see that with carbo. So exactly what those immunomodulatory effects are, we can hand wave, I don't know. But it seems to be based on what's there to start.
And why is there a difference between cis and carbo?
So I mean, there's some evidence to why that might be, and cisplatin induces obviously downstream effects related to DNA damage, and there's a number of genes that are upregulated downstream of ATR with cis that you don't see with carbo in doses that are used in the clinic, and those include DAMPs and things that might modulate the immune system.
But we don't really know.
I mean, that's all in cell. That's all in cell culture.
Okay. And so what do you think of the data on the screen, sort of comparing the differences, based on cis or carbo? Do you think there's more differences with the cis-based combinations? Those numbers look different, but not wildly different?
I mean, the proof is in the time to event endpoints in this study that only tested the concept purely of adding immune checkpoint blockade to cisplatin-based chemotherapy. So, I mean, the response rate data, I think it's harder to interpret, but the PFS and OS data, I think, all goes in that direction.
Fair. Tom, you have an opinion?
I mean, I guess the numbers look the same, don't they? And if you showed those and you flicked them around the other way, I think, and you showed them to someone on the street, it's about the same. If the numbers in grey, which happen to be carboplatin, if they were all ones and the numbers were zeros and some were above and some were below zero, you wouldn't expect all four to be above. Yeah, but, I mean, they're marginally going that direction. It's a slightly different patient phenotype. They're slightly less great. So their response rate's a bit lower, so you could expect a slightly lower increase in response. And this could easily just be a reflection of, just a noise. There's no real difference between those two. In fact, the only one that's negative is the atezolizumab -1, where the combination for response is actually 1% lower. So I look at that and think it's just a lot of grey noise. It looks about the same. I think you'd be a very brave person based off that slide to say carboplatin is clearly better than cisplatin is clearly better than carboplatin.
So you don't think the numbers are different, Matt? No. I assume you do think the numbers are different.
I mean, I think if you look at the PFS hazard ratios for the cisplatin combos versus the carboplatin combos, they're different, and those are within the range of hazard ratios that make a study positive
or negative.
Not.
Yeah, and Matt, mechanistically, Tom brought up phenotype, right? There's a different phenotype of patient that can get cis versus carbo. Does that have something to do maybe with those pre-existing markers?
No, I don't think it is, because when we look at least in Vigor 130 of patients who got cis versus carbo, the distribution of baseline, either based on gene expression or PD-L1 expression, those features in the tumor microenvironment are exactly the same in cis or carbo-treated patients.
Okay. So there's not a fundamental immune environment difference between cis and carbo patients. It's really a drug effect, whatever that effect is that we maybe can't measure. Shilpa, you're sitting in between somebody who thinks the numbers are different and somebody who thinks the numbers aren't different. Sorry for your positioning there. It was meant to really keep them more than an arm's length from each other. But
I think they're not that different, and I think it's going to become a moot point, this whole cisplatin, carboplatin story, unless there's no access to drugs like EV and Pembro, and we really only have cisplatin for those patients. But looking at these, I would more agree with Tom that they're not drastically different. And again, we don't want to compare across trials, but
we do it all the time. Yeah, we do it all the time.
But I mean, we're going back and looking at subset analyses and asking whether or not they're different when we actually have a confirmatory phase 3 study that's positive.
But that didn't have the carboplatin. So if you did that properly, it could be the trial design was really well conducted. It was a brilliant study, and had the carboplatin been included as well, and there was a cisplatin cohort with alpha and a carboplatin cohort, they could have both come in as positive.
Yeah, we can't rule that out. We can't rule that out definitively.
And if you look at the Pembro, the hazard ratio for survival actually is numerically lower than the carbo carbo than the cisplatin group. So it could be that actually Nivo carbo is brilliant too. We just don't know that.
We don't know that for sure. Okay. But we know that subset analyses suggested a hypothesis that there's biological plausibility for, and now we have a phase 3 study that established that. The other thing that I wanted to say quickly is that, I mean, regardless of what is considered first-line treatment standard right now, I mean, this is a drug that we have 30-plus years experience with in bladder cancer that cures some patients. And to sort of pass this over when actually there might be very important mechanistic insights about who those patients are and why this drug works after 30-plus years because we're going on to the next best thing, I think you have to be very careful about that. We don't have unlimited drugs in this disease to just cast things aside like that.
Agreed.
I agree with that.
I think we have a comment from the live stream.
So, comment here from Guru Sampavde. This is back to what's going on in the maintenance. It's more of a comment than a question. He says here the median time to response was short, 2 to 2.5 months with Gemcis Nivo, and overall response and especially CR rate was higher with chemo IO. So the combination worked early, and more patients completed all 6 cycles of Gemcis in the Gemcis Nivo arm, partly due to a less PD as best response. It was not a situation where PRs were being converted to CRs during maintenance Nivo component. So I guess that's more of a discuss amongst yourselves.
Well, I think it gets to getting more active drugs to patients earlier, right, so that they're not progressing. Right, maybe like the IO-TKI story in kidney cancer, right? We're getting more active drugs early, patients aren't progressing, and therefore they can be on therapy longer. So we agree. Tell Guru we agree. All right, Jonathan, I didn't give you a chance to comment on this slide.
I mean, the only thing I want to say is that cisplatin and carboplatin are not the same drug. Yes, they have the same target. Cisplatin is 300 times more potent in inducing DNA damage compared to carboplatin. And designing all these trials initially to mix both of them, I think, was the fatal error in the last generation of trials. And the only trial that did it right was the nivolumab trial, where they picked out the population that they thought would benefit the most. So, you know, I think the idea that they're interchangeable is wrong, and we've known that for a long time. I mean, we've never had good head-to-head comparisons, but every time we've done it, carboplatin looks inferior, and it's not surprising that carboplatin-based combinations are inferior. So
I think our last slide of this session is different scenarios, and we're going to talk about what would you choose where. But let me just ask you one now. Like, let's say you don't have access to EV Pembro. We'll talk about next. You have a carboplatin-eligible patient, but not cis. Would you give Nivo with it?
no, but I would give avelumab maintenance.
Fair. Tom?
I can see both approaches being interchangeable, largely. I think the data supports nivolumab and cisplatin,
Right.
and I can see why that would be attractive. I could also find it hard to argue with someone who comes back and says, I'm going to give maintenance.
Do you see how Jonathan gave a nice short answer? It was very succinct. Yeah. It was very, like, right
pass
on.
Me by,
Decisive.
pass me by. Pass me by.
Keeps my
please,
consults
please.
much shorter.
Yeah, exactly.
No, so I think that they're interchangeable. I can see arguments for maintenance of avelumab. I can see arguments for chemo nivolumab. I do feel that if you were a patient, you'd say, I want to have the immune therapy up front rather than waiting. I can see the argument for that.
Shilpa.
A question about whether
You don't have access to EV Pembro. You got a carbo-eligible patient. Are you giving Nivo with it, or are you just doing Gem Carbo with avelumab?
Gem Carbo with avelumab, based on the
Based
data.
on level 1 evidence. Same.
Yeah, me as well.
Fair. Yes, David. Oh, yeah, question, sorry.
Yeah, thanks.
Sorry.
I just want to say, Matt, I really want to believe. I think whenever you can introduce biology into the answer, that's phenomenal. But the one thing I haven't heard anyone discuss, and maybe I'm just not thinking about this right, but I haven't heard anyone discuss the fact that patients that can go on to a trial with cisplatin might just be better protoplasm.
But then,
And sometimes, oh, go ahead.
no, go ahead.
No, I was just going to say, I mean, time and time and again, the worse the performance status, the harder it is for anything to show benefit. So if you allow trials with patients with a worse performance status, with worse protoplasm, it's harder for anything to show benefit. Maybe, again, I hope you're right, and I like to talk about this too. And I love cisplatin, but maybe it's just patient selection.
So I think it's a great point. One, in the IMvigor130 data, this relationship with baseline PD-L1 expression, propensity score-based adjusted analyses or matched analyses For patients getting cis versus carbo, you do not see that effect in patients who got carbo versus cis. So it doesn't seem to be driven by other prognostic factors. There seems to be biology there that's real. The other thing that comes up about that is, of course, these drugs were approved as single agents in cisplatin-ineligible patients way before these studies were done, and we saw response rates in the 25 to 30% range. So I don't totally buy that this group of patients is somehow not susceptible to immune checkpoint blockade.
Yeah, fair. All right. Tom, this is your slide. So this was about the OS from the start of chemotherapy, right? So when we talk about maintenance of avelumab, obviously there's 6 months or 4 to 6 months, 4 to 6 cycles of chemotherapy beforehand, right? So the clock didn't start ticking in that trial till patients were randomized at some time point later. So Tom, maybe I'll turn this to you and just say,
I think we sort of discussed this.
Yeah.
I think one of the issues which I think and I'd be interested in what the panel thinks around this, is we're hearing that maintenance of avelumab is associated with 29 months survival. Because when you look from the time of completion, of time of randomization, you move forwards, that's 21 months, and then you add the retrospective period for chemotherapy on, that makes for 29 months. But that's not 29 months in unselected patients. That's 29 months in the group in the maintenance of avelumab trial. And that suggests to me it's quite a highly selected group of patients. And so you kind of can't have it both ways. You can't, because we know from the Pembro trial, everyone got Pembro, so you got chemo and then maintenance Pembro. So it's very unlikely maintenance of avelumab is going to be better than that from a median survival, and that's 17 months. So it suggests that the best you're going to get with maintenance of avelumab is about medians of 17 months, not 29 months. And I just wanted to make that kind of point, and I wanted to see what other people thought around that 29-month issue and whether it's realistic or not.
more math.
I think it's unrealistic.
Jonathan says unrealistic. Yeah, Shilpa
right? I mean, you look at the Gemcis-Nivo data, right? I mean, it's the same experiment as this, except just with cisplatin. You don't see that dramatic lengthening because you're picking a population that's already done well. You pick the winners, and the winners do better.
Yeah.
That's
in every trial.
Yes. Well, that's conditional probability.
Right.
The better you do, the better you do. That's how it works.
I agree.
We agree on something.
All right, we agree.
That's first.
All right, this is one of the polls that we put out. 65-year-old male smoker, performance test 1, good creatinine clearance, good hearing, no platinum contraindications, lung and liver mets. This is our transition into the EV Pembro data. What we use as first-line treatment if all options are available. You can tell Tom made this question because avelumab is spelled wrong. You can always tell Tom's fingerprint on anything is some misspellings. So most, 80, almost 85% of patients said EV Pembro, and we're going to talk about the data, but still a little bit of what we just talked about, right? Either Gemcis with avelumab maintenance or the 901 data. All right, let's look at the efficacy data for EV-302. Tom presented this last Sunday, 2 weeks ago. PFS on the left, nearly doubling of the median PFS. You see the OS nearly a doubling, again, corresponding hazard ratios, which are in the 0.4-ish range. Bottom left is response rates with nearly a 30% CR rate to EV Pembro. And then the forest plot, I don't know if that's the OS or PFS forest plot, I think it's PFS, that basically shows a uniform benefit, kind of what you want to see in a forest plot. So, Jonathan, I'll ask you first. I mean, I guess, is there anything wrong with the efficacy data? I mean, or is it pretty darn good? And
this is completely consistent with the 2 prior studies of EV Pembro. In cisplatin ineligible patients, this is a mixed population. EV Pembro, at least in terms of response rate, is the same trial after trial. EV itself is the same trial after trial, and it's very different. I think there's underlying biology that we have yet to really understand with enfortumab that changes the natural history of the disease, at least in some patients, based on my experience with single agent and with combination therapy. And so this, while I wasn't expecting 31 months, I was not surprised by this data.
I mean, what's remarkable, as you just alluded to, is the consistency, right? Usually you get the early, highly selected patients and the response rates are high, and we say, oh my God, it's great. And then you're sort of knocked down in a big randomized
Sometimes
trial.
Sometimes they go up from trial to trial with this drug.
You're right. But to me, that's what's surprising, as you say, both single agent and combo, the numbers have almost been bang on, right? Every time, just high 60s, 70%. Shilpa, anything to add in terms of, you want to poke some holes into Tom's data? I'd love for you to.
No.
Matt, anything to add to the efficacy data?
I mean, just that this is what non-incremental improvements in oncology look like. And I don't think we've seen a lot of this in bladder cancer in the past 30 years, or in other cancers necessarily. And so I think the data speak for themselves.
Why do these drugs work so well together? Right, and we've just talked about chemo IO, and maybe there's something, maybe there's not, and like we kind of tease that apart, but nobody disagrees that these drugs play well together.
And I think we're in a somewhat unique opportunity in this field, because this is an observation that hasn't occurred in other solid tumors. You know, it's you slap the chemotherapy backbone together with immune checkpoint blockade, whatever disease it is, and it seems to work. But I think here we have a gradation of benefit with carbo to cis to EV that clearly points to different biology.
And there's good preclinical data suggesting that EV's really leads to immunogenic cell death. What that translates to down the road is, I think, hard to know. There hasn't been, and I'm ashamed to say, there hasn't really been much correlative work that's been truly done with this. There's been some, and there needs to be more. Hard to understand this change. Because we need to be able to build on this, right? We're still not curing. We may not be curing anyone. We hope we might be, but we need to do better, and we need to understand what's really happening.
So Matt, you think that the favorable changes from carbo to cis are another notch exaggerated with EV? Is that fair to say, or you'd speculate? I know we don't have the data. But.
Yeah, no, well, I don't know mechanistically if they're the same at all, but just in terms of the clinical responses, I think that's what we're saying.
Shilpa, you're seeing a bladder cancer patient Monday, you're about to give them EV Pembro, and they say, hey doc, can I be cured of this disease? And if so, what's the % chance?
I don't use the term cure with my patients, for the first time, and I think once we see the first scan, and I tell them they can live with this disease for a long, long time. But I think looking at this data...
I want a better answer. I want to be cured, doc. That's why I came to you. I want to be cured. Can I have long-term remission, whatever you want to call it?
Yes, they can.
Yes. How likely is that?
As the curves here show, it is very likely. And I think we now have to talk about what next after this, because there are some patients who do go through EV Pembro. And we've seen that in the trial, because if they progress while on EV Pembro, then there's really not a whole lot of great options.
I think it's reasonable to say, sorry, you go.
No, I think the data, not just from this trial, but the cohort A long-term follow-up and dose escalation is showing that perhaps 40% of people are going to be alive after 3 years, and that's...
And that cohort A, remind me again,
that
the
was
population?
The initial, so cisplatin ineligible, first line, untreated, EV Pembro. The 4-year follow-up was just presented, and the data is pretty remarkable, in my opinion. I mean, it's 45 patients.
44%.
Okay.
Right? 45 patients, small numbers, but it doesn't look that much different than what we're... If those curves continue like that, we're in a 30 to 40% range easily with long-term non-progression.
And we just talked about the consistency of data, so hopefully that data will hold up. Obviously, we don't know, but Matt, what do you think? Are you telling patients there's a chance of being cured of this disease?
I mean, even with cisplatin with immune checkpoint blockade, we know that there's a subset of patients who can be who can have no evidence of disease and be off treatment for a prolonged period of time, and that's documented now, and that's what I consider, potentially cured, although we don't use that word. For obvious reasons. Most of these patients are still on treatment. Most of these patients still have something on their scan. I think we have to be very cautious about calling those things the same. Cure to me means you're off treatment, you have no evidence of disease, and it's been years since your last treatment.
Okay.
So question, first of all, a big complaint against Dr. Rini, because he told me specifically you should not dress up Boston. Don't wear your tux. You have to be like you're on vacation. So I come here and I'm just a mess.
You look great.
Anyhow, I'm gonna challenge actually Jonathan and Matt. I think we all, and this is an area of research, the three of us, our translation research biomarker. I do not, when I go on record, I do not think, I know you will not find a biomarker for Pembro EV. The reason, if you look at all oncology, once you don't find a biomarker for a single agent, a clean pathway, you're not going to find a biomarker for a combination. It hasn't happened. So, and it's fine because things have gone extremely fast. Jonathan, of course, him and Ellie and others found the DNA damaging, was it ERCC1, which didn't pick up, that's fine. But all what I'm gonna say that you may not be, then don't forget, Matt, 70% response rate, and you know well that the next study gonna be having Pembro EV as control arm and adding a third drug. If it's successful, gonna be 90%, then it's gonna be like BEP in testis, which is great. So I'm not saying, I'm saying that this is what I do and you do, and we didn't come up with anything yet.
But I don't think we do it.
Go ahead, Matt.
I don't think we do it only to find predictive biomarkers. We do it to determine whether or not there are mechanisms of response and resistance that could be exploited to design that 3-drug regimen that you're talking about.
Right, but when the PD rate is less than 10%, 5%, and the response rate, especially if durable, it's that high, maybe we can do it to see who can go back and see who can respond to a single agent. Why can't I give someone EV alone and cure them? But then you won't have those population because people will not gonna receive EV single agent. This is the problem. It's a great problem to have, but it's a vexing problem for the 3 of us.
So I think doing none of it is not the answer, and I'm sure you're right that it's not gonna be easy to find the Holy Grail, and I have a feeling we'll never get there. But we have no understanding right now, and this is a different therapy. This is the first combination checkpoint and ADC in solid tumors, I think in all cancers actually, that's approved in this way. And we've done no prospective evaluation of biomarkers whatsoever with EV. Really.
I am with you, but the triplets are gonna come.
Right. Oh, I agree.
Jonathan, in the cohort K of EV103, we saw the activity of EV mono. So to Tony's point, Pembro is adding to this, obviously.
Right.
Clearly. Petros?
Great discussion. Just to piggyback on the previous comments by Tony. So fantastic data, transformative, practice changing for sure. If someone can access EV and Pembro, especially in the US, many countries may not have access to it, but that's a separate discussion. 3 quick practical questions for this fantastic group. What do you do in patients with prior IO exposure, adjuvant, nivo, or some other clinical trial using IO in the neoadjuvant space? That's number 1 question. Number 2, the trial was correctly designed. If it was continual progression toxicity, how do we design the escalation trials down the road? And the third question, if I may, is how do we handle ongoing trials with chemo available as a comparative arm?
Petros, it's like you've seen our slide set because we're going to cover all of that.
And I have not.
So at the end, we're going to talk about scenarios including adjuvant immune therapy. The next slide's on toxicity, and I don't remember your third question, but I'm pretty sure it's covered. Oh, what's going to happen to future trials? Yes. We're going to cover all that in the next 20 minutes and 3 seconds.
Fantastic.
All right. Let's see. Tom, I'm going to end with you on this slide about cure. People are getting like skittish at the word cure up here. But whatever you want to call it, long-term remission, right? Long-term disease control, right?
So I think there is long-term disease control.
Brief.
How likely is that? Tell me, Doc. Give me a number.
I'm going to agree with Jonathan. I'm going to go with.
I'm
When I see patients, I'm saying somewhere between 30 and 40% of patients are getting unusual benefit, which we've not seen previously.
So maybe a 1 out of 3 chance.
I would strongly recommend these regime because, as Matt said, the results look transformative, and one of the reasons for that is these response rates is very high. They're very durable, and there's a subgroup that's doing exceptionally well. We don't know the 5-year data yet, but there's a chance that you're going to be here at that point.
Awesome. All right. Toxicity. This is the tornado plot from EV302. You can see the different toxicities there, including neuropathy and rash, and some of the ones we're familiar with, and then obviously the cytopenias, et cetera, from sort of the traditional chemotherapy. So maybe to Petros's question around de-escalation and giving this in practice, and Jonathan, you have a ton of experience with this regimen. How much EV is necessary? How much can you give? How do you modify? Because obviously, in the real world for non-trial patients, it's going to be totally different.
Right. I think one of the things to be reassured is that you can dose reduce and take breaks with EV in patients who are responding without tremendous negative consequences and probably only positive consequences for toxicity. The problem that happens is the peripheral neuropathy takes a long time to improve, if it improves. And if you get to a point where there's severe neuropathy, you may not be able to turn that ship back around. Yeah. And so I think, one of the big questions we're going to have to answer is, can we de-escalate? There's different ways to think about doing it, EV, in order to not seriously affect clinical outcomes that the patients are interested in, which is living longer and living better. They don't always go together, living longer and living better. And so it's a real challenge that we have to face. And in clinical trial design, it's hard to get at that. And you know, do you pursue a maintenance strategy? Do you de-escalate by dropping an EV dose? I think this is where we have to make some careful thought about how we do this with EV Pembro. Do we look at the colon literature and where they have modified oxaliplatin, where you stop after a fixed number of cycles in responding patients and wait and resume? You probably can do that with EV, is my guess. But you know, we have to have the stomach to do those trials, and we have to have patient buy-in because you know, if you're responding with a terminal illness, do you want to stop it? Maybe you'd rather walk around with a cane.
Right. Shilpa, I was going to ask you, do we need to do those trials formally? We've struggled in oncology to do de-escalation trials, right? In RCC to stop the TKI or whatever. I mean, we've just struggled to do that. Limiting IO trials, those have been a disaster, right? So can we do the trials? Do we need to do them? Or is this just one of those clinical practice things where you get familiar and you have patients and you say, yeah, you know what, I can de-escalate and I know it's not a big deal, or I can dial back or whatever?
I think we do need to do those trials for a variety of reasons, to have a clear understanding, you know, also for financial toxicity besides physical toxicity. I just don't see the rationale of continuing EV indefinitely, even after pembrolizumab stops at 2 years.
Yeah.
And we've used intermittent approaches even on patients on the study, like finding reasons not to give it to them because they are in CR and really cruising through, you know. So we need those trials for sure.
And I don't know about this study, Tom can comment, but most studies aren't written to de-escalate for clinical common sense. Like the patient's in CR and they have a little neuropathy, of course you'd stop that patient, but study protocols aren't written that way. Tom, did you want to comment?
No, and I think one of the issues with this study is that we hadn't had a successful trial for survival before. And so the thought of tinkering with the kind of arm to de-escalate and then have a negative trial, that would have attracted quite a lot of criticism. So this was the attempt to get over the line, improve survival. We didn't think we were going to get these results when we launched the trial. About halfway through the trial, many friends and colleagues were phoning up saying these results were exceptionally good. Jonathan produced the 103 and the cohort K data, and I think Peter's in the audience too, and I think I remember I gave a talk at ESMO, I think, after that original data set was presented, and my trial was very negative. It was a study called Calypso. It was largely recognized as a disaster. But presenting after that was extremely challenging because it was obvious to me at that moment that this had the potential to be transformative. And it's the consistency of the phase 2 and the phase 3 data, I think, is for me really impressive. And that's been consistent throughout the EV program. It happened in 301 as well, the monotherapy.
Okay. Tanya?
So I think it would be great to do a prospective trial, and that would be a great place for a biomarker to be embedded, maybe something like ctDNA looking at minimal residual disease, like when have we debulked enough that we can now drop the EV and maintain. So if we're going to do something prospective, I think that's where biomarkers could be very helpful. But even if we do not, because those are hard trials to do, we need to get the data out for what happened in this trial. So I had a patient on this trial who I inherited who went from dancing to being in a wheelchair. And I said, whoa, let's stop the EV and just maintain, and he stayed in CR. But when the clinicians are looking at these data, they don't know how much EV was given, how many people stopped, and was their remission maintained. So I think there need to be really honest and granular presentations about how many doses did most people get, and the fact that their remissions could be maintained even when you dropped the EV.
So there was a very steep learning curve, both from a skin toxicity perspective and a peripheral neuropathy perspective. And I think that the peripheral neuropathy is cumulative, and it's motor and sensory. And that, and if you treat through that, it's as bad as treating through neutropenic sepsis. You end up with the devastating side effects that you get with any chemotherapy when you're on the learning part of that learning curve. And the same applies with early skin toxicity. If you get skin toxicity in the first 3 cycles, a skin rash, and you treat through that, there's a likelihood that you're going to get into a lot of trouble quite quickly. I think that from my perspective, and there was a French experience, which many of you in the audience may know about, where the French wrote a paper around skin toxicity that they saw. There was then a huge education and training program in France that Astellas led extremely successfully. They then did an expanded access program, enrolled 1,000 patients, and didn't have the same instance again through education and training. And so as we introduce new drugs into oncology, we need to, in parallel, have excellent education and training. If we introduce cisplatin tomorrow, with its nephrotoxicity, with its neutropenic sepsis, with its emetics, it would never see the light of day. But we've got used to doing that, and we're good at it now, and we need to get good at giving EV Pembro as well.
Also, because I want to add, patients underreport their symptoms when they're on EV Pembro as opposed to being on chemo, where they overreport everything. So it's the clinician's job to really do a good physical and old-fashioned history taking to get those symptoms out.
Well, right. And
do a skin exam.
To Jonathan's point, patients don't want to stop drugs that are working, right? Right. Even if it's okay, right? I mean, to Tanya's point. Okay, one more quick one, Tanya.
One small thing. First of all, congrats, Tom. This is the first time I hear British person talking positively about the French. So good for you. No, honestly, good for you. That shows me growth and maturity. But one thing is, and Brian knows that maybe the answer is not response. EV, certainly, I had a lot of patients with neuropathies, debilitating. Perhaps to focus on germline determinant of all these neuropathy from EV. It has to be not just the dose only, but there are folks more sensitive than other to neuropathy. And that we could do.
Yeah, and I mean, that may be the kind of biomarker that's most useful, right, is some sort of early neuropathy or whatever, or that's a SNP or whatever, so. Okay, here's our scenario slide. We've got just over 10 minutes left. So these are 5 different patient scenarios. So frontline advanced bladder cancer of the different scenarios, and then you've been given a colorful 6 treatment options. Again, you can tell Tom made the slide because the green box platinum is misspelled. That's a new type of platinum called platinum that's not toxic. So first one is no prior immune therapy, platinum eligible. Shilpa, this is an easy one. No prior immune therapy, which you can give one of these options, right? Is that how it's meant to be, Tom? You can give one option. Pick one.
Yeah, I think it's great to have multiple options, and we can, if there's no contraindications to cisplatin, you would discuss Gemcis Nivo, and you obviously will discuss EV Pembro.
Which one would you give? Let's assume access to everything and insurance and all
EV
that.
Pembro.
EV Pembro. Okay, anybody disagree? Good. All right, this is the one I think that, Petros, you were talking about, adjuvant immune therapy within 12 months. So patient gets adjuvant Nivo, 9 months later, they get a scan and have progression, needs systemic therapy, and are platinum eligible. Matt, you're an adjuvant Nivo kind of guy.
Yeah, if someone's cisplatin eligible, which is that's sort of a weird scenario because generally those patients get adjuvant cisplatin if they would have been eligible. But if they didn't and they got adjuvant Nivo, I would give them cisplatin-based therapy as first line and then EV as second line.
Okay, so you would not give EV Pembro, you'd give them you'd give them just Gemcis.
Yeah, within 12 months I wouldn't. I mean, it's arbitrary, but I would.
You'd give them Gemcis, and how about maintenance availumab if they respond?
I would not.
You would not? Okay. Shilpa, you agree, or?
Yeah.
Okay. Tom?
I think it's difficult, isn't it? I guess you kind of look at the EV Pembro results and you think if there is something going on that's positive between those two, you might say, that third line enfortumab vedotin is not associated with these durable remissions we saw previously. You might, though, come back to me and say, well, if you're failing adjuvant therapy or the cancer's growing at that point, then nothing's going to work. I think it's an area that we need to look into in great detail. And I think it's one of the questions we really have to answer, because a lot of patients are going to get therapy in the perioperative space, and so this isn't going to be an unusual consequence. Right. But it almost begs the question, if you said to me, am I more impressed with the adjuvant Nivo data, and how many patients is that curing, or am I more impressed with EV Pembro? I'm more impressed with EV Pembro. So why give adjuvant therapy at all, and why not wait in that 30% in whom it comes back, and then give a regime that's associated with a 30% cure rate?
Tom drops that bomb with 8 minutes left in the session.
But you know, that is a question. Without a survival signal in that maintenance, in that value, you're giving 100% of patients adjuvant Nivo. We don't know if they live longer, but now you're saying they're not going to get EV Pembro, which has got a 40% durable remission rate. I would just say I'd like to wait, and if my cancer comes back, I'll get EV Pembro, which has got great results, until I can see a survival signal.
We made it 52 minutes without bringing up the adjuvant Nivo survival data, which is longer than most podcasts, right? Usually we're 10 minutes in. What do you think about that? That basically the EV Pembro frontline data obviate the need for adjuvant Nivo.
No. I was going to say something.
No, please.
I was going to make a smartass comment, but it's actually.
Welcome.
But I think it's actually it is a important consideration. If we're not curing patients with adjuvant therapy, should they get the best combination when they need the best treatment? And I think it's a very reasonable, it's a reasonable question. I think we are curing patients with adjuvant treatment, so I would not do that, but I think it's a reasonable question.
Okay. And Jonathan, I want to ask you to tie break, but are there patients who get adjuvant immune therapy that you would still give EV Pembro to, maybe?
I think some of that is interval between the end of immunotherapy and relapse.
How much is long enough for you to consider EV Pembro?
You know, at least 6 months off of a checkpoint inhibitor, I would say. And it's completely arbitrary. Who the heck knows at this point, right? I mean, there's as many opinions in this room as there are people, and we have no idea. But I think both Tom and Matt's points are very well taken, and I think I'm hoping, and we think we're all hoping, perhaps that EV Pembro is going to leapfrog into the perioperative space, which then makes this somewhat of a less relevant question. Of course,
I think that's our next slide. Yes. Right. Okay. Let's see. The middle box there. No previous therapy. EV not available and platinum eligible. Jonathan, I'll let you take this one.
I mean, I think Gemcis Nivo, if the Nivo is available, is very appropriate under the circumstances, and the data justify it, in my opinion.
Okay. Anybody different? Good. Okay.
I think, but it wouldn't be the wrong thing to do to say maintenance of avelumab's okay.
Sure.
Wouldn't be the wrong thing.
Yeah. Fourth one, perioperative cis and immune therapy within 6 months. So this, maybe somebody who got neoadjuvant or adjuvant therapy?
Yeah.
Is that?
So neoadjuvant chemo, cystectomy, and then halfway through adjuvant Nivo.
Progressed on adjuvant immune therapy.
I would do EV mono in this case.
Here.
I think that's reasonable.
EV monotherapy?
Yep.
Matt, anything to add?
Why are all the treatment options in different colors?
This is like the inside of Tom's brain.
It's totally my fault.
Very scary place. It's
EV monotherapy as well.
okay. Let's see, last one. Poor performance status, poor exercise tolerance, diabetes but control. So kind of obviously the poor performance status patient, right? Those patients who are maybe in the old days you debate treatment or no treatment or single agent immune therapy. Shilpa, what do you think?
PS2 is a classic indication. We've been treating these patients. I would use EV Pembro for this patient.
Others' experience with EV Pembro in this population, in this real poor performance, probably not a trial candidate, right?
I would, if I tried EV Pembro, I'd start out with a dose reduction of EV. And if we're going to go there. Otherwise, single agent checkpoint.
Okay. Tom?
I agree, John.
And what would you dose reduce to?
Probably 1. And I'd be cautious on the day, on cycle 2, day 1, I'd be super cautious. I might not even start that until, I might give an extra week off on the first cycle, just make sure things are okay, and then go from there.
And the renal function, would love to know what your threshold was there. If it was below 30, then I would not give EV Pembro.
So renal function doesn't seem to be an issue with EV, right? There are patients who have end-stage renal disease who've gotten it without problems, and there was that small cohort from the phase 1 study where it didn't seem to make a difference. So, and this is the one thing to point out, and everyone most of us understand this, that PS2 from cancer is a great reason to give EV Pembro, right? Because those people are the ones where it's like a Lazarus-like response, where they arise and they jump out of their chair 6 weeks later. It really is, can be remarkable in that respect. Even EV monotherapy has done that in patients that I've seen.
So it sounds like EV Pembro, but maybe modified, to be a little more ginger in its application, right? Okay. All right, I think we should have a couple slides
Well,
left.
we're going to talk about this later on. So why don't we get on to the next slide? Because this is the last issue that we've asked the panel to ask about.
Other ADCs. Yeah, there's a number of ADCs out there. Matt, I know you've done a lot of work, so I'll ask you to start. This is the TDX data, but where are we going with other ADCs? Is this just an EV thing, or is it more broad in ADCs, and now this is what we're going to be talking about for the next while?
Yeah, I would say the next few Euromigos meetings, 2025, we're going to be talking about ADCs. I think ADCs are going to probably dominate the discussion in the next couple of years as we start to see combinations in different targets with different payloads that are non-cross resistant.
Okay. Tom, comments on other ADCs?
I think the second group of ADCs, I think sacituzumab govitecan, the response rates don't look quite as high as enfortumab vedotin. And so I think not all ADCs are equal. And I think disitamab vedotin's got some nice data. I don't think TDXD is combined, and sacituzumab govitecan is combined as well with immune checkpoint inhibition as EV Pembro, and the data we see with DV and immune checkpoint inhibition. So I think that it's going to be, each dance partner is going to be somewhat unique, and the assumption that all of the results are going to come in the same as EV302, I think, would be flawed.
Agreed. Jonathan, anything else about, or Shilpa, anything about? I think these are only other ADC slide.
The only other thing I would say is that I think payload matters here, and that's probably responsible for the interactions with immune checkpoint blockade. And at least in bladder, I agree with Tom that the topo-1 inhibitors haven't seemed quite as impressive in their interaction, in a positive interaction. They may not be negative, but I think it's something to consider. And we've only seen two ADCs really. That's right. Two classes.
Right.
I agree.
All right, and Petros, I think you asked this before. Now that we have EV302, what's going to happen with these trials? Shilpa, I'll start with you with that trial on the right. You've done, and I know you have ongoing cooperative group trials in the maintenance setting. Can that trial accrue still? Is it still relevant to try to build on maintenance avelumab, or is that going to go away?
Yeah, that's $1 million question. Only Jonathan and Matt can answer. But
not to put them on the spot or anything, but no, I mean just conceptually, like what
I think it's still a fair question, whether or not, I think after the uptake of EV Pembro, we'll have to revisit that, but given that 70% patients did not get maintenance avelumab in EV302, and only 80% did not get in Checkmate 901, I think it's still not an unethical thing to do, and it all depends on, how much we can accrue before calling it quits, or at least getting to at least 100 patients.
But will you struggle in the control arm of the DV Pembro trial has got standard chemotherapy and avelumab? I'm guessing that's going to be difficult in the US.
For this particular
so on the left-hand side...
So Tom was commenting on the left-hand side of the trial with DV Pembro.
Yeah, so both of those studies in the US, I'm guessing that you're going to...
This wouldn't be an applicable control arm in the US, if that's the question.
And so alternative approaches will need to be sought.
I think EV Pembro will have to be the right control arm for these studies.
In the US?
In the US.
Jonathan, do you?
Yeah, I think this is going to be a tough sell in the US at the moment, or will be very soon. And I'm not sure that perhaps DV and Pembro is going to be better than EV and Pembro, but
it's going to be hard to show that.
It's going to be very hard to show that.
Yeah.
It might be not that hard in HER2 3+, actually, right? That data looks quite good, and maybe better than EV Pembro, but it's such small numbers.
Yeah, Matt.
I was going to say the same. Maybe 2+ as well, but I think there's a subset that this regimen could have an edge, and then it's just designing the trial in the right way.
Yeah,
Need the right biomarker.
To accrue. We're out of time. We'll end with this. We're going to talk about sort of what to do next. This is sort of Tom's thought. I think he showed this at an ESMO discussion.
Perfect spelling, I think.
I think this was the discussion where you didn't know you were moderating until halfway through the session. I think it was that one. So maybe we'll go down one last word in the panel. Matt, we'll start with you. You have all the money and resource in the world. You can accrue whatever you want. What trial are you doing next? Frontline bladder cancer.
Yeah, I mean, I think based on the limited phase 1 data that was shown at ESMO, if that holds up, this is a reasonable study. I mean, just thinking about data that we have in hand, that could be a very practical study. I think this is a study that makes sense.
Shilpa, it doesn't have to be this study, but would...
Right. This study would make sense if there's a finite number of cycles with the ADCs.
Yeah, because all our considerations about toxicity are now doubled, yes. Tom, I know this is yours, so I know you agree with it.
So I think looking differently, I think there are some de-escalation studies that we really do need to do, and I think the cooperative groups need to look at that. And I'd like to see ctDNA brought into a new generation of trials.
Excellent. Jonathan, last word, frontline advanced bladder cancer.
I think we need to see if we can improve on the immune responses that we're getting with EV-Pembro, and so I would advocate exploring novel immune combinations with that doublet.
Yeah, so not just building another cytotoxic ADCs, but other novel checkpoints or whatever it may be. So, all right, and with that, we will end our live stream, end our frontline advanced bladder cancer. Thank you all for joining. Thanks to our live stream audience. We're going to switch over some of the panels now. For people on the next panel, if you're not mic'd up, head to the corner and get mic'd up. And then I'll thank this panel and have the other ones come up. And the next one's going to be a live podcast, kind of, sort of. So.